Lecture from earlier this afternoon. I just have to do a small presentation. Our speaker really doesn't need an introduction. Dr. Jerry Bouquot is professor and chair of the Department of Diagnostic Sciences at the University of Texas Dental Branch in Houston. He was also an adjunct professor of the West Virginia University School of Dentistry as the oral pathology head of the department for 17 years. He is a co-author of the most popular oral pathology textbook in North America and parts of the world. He presents more research and continued education seminars worldwide than any other oral pathologist known to mankind.
Okay, thank you. And sorry about not having a nice division between the topics here, but I ran a little bit long on the little introductory thing. This is actually the part that I like the best because I think we're pretty right in our assumption that these problems are related to the crack and cocaine, mostly direct contact with it. Before I got to Houston, I didn't even know that people put crack and cocaine in their mouth. I thought they put it up their nose or they smoked it. But as it turns out, there are quite a few people who do that. Was there a question? Crack is different from cocaine. Crack comes in, it's the cheap man's cocaine, essentially. Cocaine, if you read, I'm a big reader, and if you read the old British novels, they were usually upper-class people they were talking about, and at their parties, cocaine was their deal. And people would start having a nasal speech sound in some of those novels, and that was from the perforation of their septum. But crack is, it's very cheap, so then it's a little different product. I'll go into that. This is... It inhibits dopamine and norepinephrine uptake, and so these products build up. I've not read in any of my literature. I don't claim, remember, to be an expert in this. I just happen to be the person who's looking at this in the urgent care clinic with C.D. Johnson. But it is a stimulant, and it gives a very nice euphoria feeling, much better from what people tell me than alcohol does for them. It's a much better high. The problem is it's not as... It isn't as dependable as an alcohol high. Usually, if you have a drink and you have a good time with that, the next time you have it, you'll have the same experience. But with cocaine, there's a lot of up and down. You might have a bad experience right after a good experience. And that's what they tell me anyway. It is very addictive, not quite as addictive as methamphetamine, but very highly addictive, probably heroin, and then methamphetamine and crack cocaine both have about the same addictive levels. It comes in a powdered form, and it can be dissolved in water so that you can inject it, but most of the time it's either snorted up the nose. As a matter of fact, I don't know how many of you know this, but if you stretch your thumb and your finger out, you'll see that little indentation in the skin fold, and that was called a snuff pouch because they would put snuff up their nose. It's also the cocaine pouch. Everybody would fill that little thing with cocaine and put it up to the nose and snort it up the nose. Now they just use $100 bills to make these lines on the glass mirrors and on the tabletops. Freebase is something that it's not neutralized. It's a little different chemical formula, and freebase can be made into crack. And freebase can be, the reason it's called crack is because when you take these chunks and put it in the pipe and burn it, there's a crackling sound that goes along with it. That's where the name comes from. So you always want to we certainly do it in urgent care, but you want to make a quick look up somebody's nostrils because cocaine users, maybe more than any other users, even light cocaine users, like to come into your office with a little bit of a high because they get through your procedure much better. What they don't know is there's diminished healing and there's increased risk of blood flow. Blood bleeding problems if somebody has crack in their blood. So, whoop. Little white powder or yellowish. Pure cocaine is pure white, and that's why it's cut with baking soda and things of that nature, other white products. But a really not so great cocaine powder has a yellowish or even a brownish look to it. Here you can see just a little bit of, that's almost a little bit of a brownish or tan coating on the nostril hairs. This is essentially how it's used. Cocaine, people chew on the leaves. People make a paste out of it, and the paste is almost always placed up against the gingival tissues. It could be placed back where chewing tobacco is, or usually it's in the anterior where snuff is placed in people's mouths. And we found that primarily it's the upper lip. They like to put it under the upper lip. Why, I don't know, but that's they don't put enough. It doesn't make a bulge. It doesn't really show if they're walking out in public, but it's there in the mouth, and it produces some fairly specific effects. I didn't know about this. I know in Peru that cocaine workers, those guys out in the field who are bringing in the leaves, they kind of chew on the leaves, the raw leaves, all day long. And they have kind of a mild high. But you can do the same. It's really not very common, a habit outside of Peru, but they just call it cocoa tea. And it's mostly the women who are drinking that in Peru. And it is why I know these kind of things, I don't know, but high altitudes where the cocoa is grown at high altitudes. So in those areas where the leaves are being brought in commercially, this is a very common habit. They would use this kind of tea the way we would use regular tea. And it just makes you feel a little more mellow. There are lots of street names for it, and cocaine, more than the others, has a little more mature level. The average age of people making up new names for cocaine is about 22, so it's a little higher than some of the other street names. And it's mixed with a lot of different products. And pure cocaine is, if you're used to taking a lot that's been cut with other products, baking soda, whatever, and you get pure cocaine, it literally could kill you because your body is not used to that dose. People who use pure cocaine, and this I've never tried, so I'm only telling you what other people tell me. If you use pure cocaine, then you start out with a little bit, and eventually, as the tolerance builds up, you take more. But if you're used to a cut product and then take pure cocaine, you could be in serious trouble. So this is what the crack looks like. They're called rocks, and these are ground up. People tell me they pound it with a big soup spoon, the back of a soup spoon, and just make fine powder or smaller rocks, and they can make a paste out of it to put in their mouth, or they'll put the small rocks into a pipe. And I don't know if you realize this, but this is still an available product. There are sprays of cocaine that mostly are used by ENT. If they want to do a biopsy of the posterior pharyngeal wall or the tonsil area, they'll just spray it with cocaine. And that used to be something that was used in dentistry, but we haven't done that for 100 years. Only 1 in 10 of us use cocaine at some point, and about 2 million of us say that we've used it at least within the last month. If we're taking crack and cocaine users, supposedly crack users are much less common, but crack is more of a poor man's product, and they're less likely to have phones and answer surveys and things like that. So who knows what these numbers really mean. There is, in the last 10 years or 15 years, there's been a much more prevalent use in the minority groups in this country. Of course, Latinos in my town, Houston, are the majority. So I'm a minority in Houston. But the typical minorities are seeing cocaine use, and that really started because they started using the crack. It is responsible for a large number of emergency room visits every day, and I just last week, if you look at these live cop shows, mostly it's cocaine or methamphetamine that people are high on. And their behavior is pretty bizarre, but it's sort of like a really bad drunk if you look at those shows. But of course, those are a select population. And there was indeed cocaine in the original Coca-Cola product. And it wasn't until I think the U.S. government outlawed most of these street drugs back in the 1920s, 1927. Anybody remember what year that was? And from that, they became controlled substances after that, and that's when Coca-Cola took it out. It is a high. It's a very short high, but some people have at least a couple hours. It's an alcohol high is much longer in duration than a cocaine high, so you have to kind of snort this stuff routinely as you're going along. But if you think about it, if you're drinking alcohol, that's what you're doing. You're just taking drinks throughout the evening. There's a long downside, so you know that the upside must really be good. I don't know why anybody would use it otherwise. And so, but these are the ones that have probably the greatest mood swings. They become very self-centered, but that's part of the addiction. You know, an addict is not worried about not only, well, they aren't worried about even their own health. They're not going to be worried about others around them. Probably the classic thing that is different about cocaine use that you might see in the face, I've got not the best picture of it, but people feel as if there are bugs crawling up and down under their skin. And this is even when they're not high. So it's just, it can be a chronic thing, can last for days at a time. And anybody who's into crack or cocaine knows that these are called coke bugs, and they scratch. So you'll have somebody, it could be on the face, could be any part of the body, but usually it's the face and the upper portion of the body. And it's scoriation. You see almost like pimples everywhere on the face from scratching these little bumps. And they're not really bumps. They're artificially created bumps. These are the people who are most likely to just sit in a chair and they'll be talking normally, and all of a sudden they're off in another conversation, and you're not even there. And that's probably more true of cocaine than any of these others. It produces ischemic necrosis. It produces necrosis in the nose, and I'll get into that. It can wipe out the GI system, any part of the GI from the stomach down through the rectum. Makes huge ulcers, so sort of like ulcerative colitis would be in the intestines. And there are some heart problems. People who are going to die of crack or cocaine overdose are going to have either cardiac arrest or stroke. Every once in a while, respiratory failure, but not so much. And this is, of all the other street drugs, this is the one most likely to be used with alcohol, and it's the one that you shouldn't use with alcohol. It has more profound serious side effects when it's used with alcohol. And here's a little bit of powder up somebody's nose there. These are the maxillofacial consequences that I'm aware of. And if you look in the PubMed or the literature, the medical and dental literature, there's nothing. That little dehiscence that I told you about, that's in the literature. They call it cocaine gingivitis. This perforation of the hard palate, we've known about that for 150, maybe 200 years. And that's about it. There's one other thing, and I'm trying to remember what it is, but I can't. It'll come to me. But these are the kinds of things that we found at the point where they put cocaine in the mouth or in the nose. Imagine what happens. Of all the parts of the body that need a surface blood supply, cartilage is it. There are no blood vessels in cartilage. So everything is diffusion from the surface. And if you put cocaine up in your nose, it's going to sit there for a little while. It can reduce the blood flow to that soft tissue by 97%. Your anesthetic produces 70 to 75% diminished blood flow. But this stuff is not only a good anesthetic, it also is a vasoconstrictor all by itself. And it is even used by, sometimes the ENT docs will spray a little bleeder with some cocaine to get it to stop bleeding. Eventually, that cartilage is going to dry out, and it will crack, and there will be an ulcer on the surface, and eventually there will be a perforation of the septum. And then every time somebody uses cocaine again, gravity is going to pull the little powder particles down to the bottom of that defect, right? And so they're going to sit there and probably get caught there and then do their thing, their ischemic thing for a while. And eventually the bottom part of that septum perforation gets lower and lower until the cartilage is gone, and now we're in bone. Bone has a lot more regenerative capacity than cartilage has. So most of the time it stops right there. But in some really heavy users, the bone itself becomes so ischemic that it gets destroyed, and the destruction is exactly like bisphosphonate osteonecrosis. You can have destruction with very little inflammatory response. You can have destruction of soft tissue as well as hard tissue. This is somebody who had a cocaine problem 20 years earlier, never had any money, never could get it fixed. She brings Wonder Bread to work every day. She mushes it up and fills each of these holes at least 5 or 6 times a day. That's how she gets through work. So nobody really knows that she has this nasal voice. And so this is, if you were a physician back in the 1890s, 1880s, if somebody came to you with a perforated palate, it had to be one of 3 things: either cocaine addiction, tuberculosis, which likes that septum as well, or tertiary syphilis. Those were the 3 things that would put a hole into your nasal sinuses. So we've known about that for a long time, the perforated septum as well as the perforated hard palate. I presented or reported for the first time ever in our National Academy about 3 years ago 3 examples of cocaine osteonecrosis, which are exactly, you'll see this, exactly like bisphosphonate osteonecrosis, exposed bone that just doesn't heal and doesn't heal and doesn't heal. And I'm sure it's from ischemia. I mean, all osteonecrosis has to be ischemic in one way or another. But these are all the things we found. I'll go through most of them. We've known about the loss of, the nosebleed. I'm sorry. The nosebleed and runny nose, those are things, somebody's sniffling in your chair and they normally aren't snifflers. You kind of get, this is one of the things you should be thinking about as a possible risk or possible parameter. But all of these others have, I'll just show you pictures of those. This is bisphosphonate osteonecrosis. This guy got in a bar fight, somebody knocked his teeth out, and 10 months later, I think this is something like 3 months later, but 10 months later, it looked exactly the same. We had this guy coming in every month, and we were just kind of cleaning out any debris under here and then taking little loose chunks of bone out. This was totally painless to this fellow. Yes. As Hal said, just wait a minute. And then here is somebody who put their cocaine back in the sort of where the tobacco chewing is kept in most people. And it developed the same kind of a thing. This has a little bit of a brown discoloration, and I think that's more either food debris or bacterial discoloration. I'm not sure exactly what. This is one that I think was probably, I think it might have been cocaine, I don't know. But this is somebody who is one of the great mysteries. Chris, I told you I had a box. If I didn't know what something was, I just took a picture and put it in this box of unknowns. And every Christmas holiday, I'd open up the box and see if I could figure out anything new. But this is a gal back in 1978. I saw her. One of our dental students at West Virginia University got a little high on a clamp, rubber dam clamp. And this bone was exposed. I followed her for 7 years. She was a teenager, and I was thinking at that time, she must have a lousy immune system. But remember, back in 78, there was really no way to tell what was wrong with the immune system. You would grow like a bacteria in a petri dish with the patient's lymphocytes, and if they went into blast transformation, like they really got large, 3-4 times bigger than normal, then you knew the immune system was able to respond to that bacteria. That was really about the only test we had. So, and she didn't have any abnormal responses in that regard. We biopsied this, and it was just dead bone. We never, after the first couple of weeks, we never saw any kind of redness or hemorrhage or anything, and after the first few weeks, it didn't even hurt. She just had this exposed bone. For all I know, it could be forever. Toward the end, when we got to be friends, I saw her so much, and she was now a mother and a family lady, and she said, I have to tell you, I didn't tell you before, but every drug that was available to me, I tried when I was a teenager. So, and we kind of chalked that up to, I mean, a lot of drugs will affect the immune system. It wasn't until bisphosphonate came along that I realized that I bet this was an ischemia problem from blood flow rather than an immune problem. But I'll never know for sure. And just because Chris was so curious, I just wanted to give you a few look-alike lesions. There are other ways. Dentistry has dealt with osteonecrosis for a long, long time. And even though I was using that word for this NICO, I mean, that's what the O in NICO is all about, the concept of osteonecrosis has changed dramatically, whereas now if you look at the researchers who are dealing with that for the hip and the knees, that's mostly living bone. It's not dead bone. So it's used as kind of an umbrella term for ischemic bone disease. Still, we're not using it properly in dentistry, but we are definitely using osteonecrosis. Well, we didn't call these things osteonecrosis, but anybody who's had a dry socket, the name itself, dry socket, tells you there was some kind of poor blood flow going on in that case. And you can give antibiotics all you want, doesn't seem to help. We think of it as somebody is smoking or used alcohol and dissolved the clot or pulled the clot out. But I've got probably several dozen cases where somebody had ischemic bone disease and the teeth were sent to me and happened to have little chunks of bone stuck to the root surfaces. And that bone's dead, even before the tooth came out. There are no bone cells in the lamina dura. And we just haven't looked at it from that perspective before. So we've been dealing with this forever in dentistry in this phase. But bisphosphonates came along in 2003, 2004. The company that Novartis that makes the cancer bisphosphonates looked in the dental literature, and they didn't find anybody but me writing about this stuff. So they asked me to be on their scientific advisory board. And when they went to the FDA, actually, I was the only dentist who went to the FDA with them. And I was the only one, I found out afterwards, who wasn't on the payroll of the company. I was the only outside person. And those FDA, I know the FDA's gotten a bad hit in recent years, but there were about 6 scientists. They grilled us. There were 15 people from the company, myself included. And they just paid my transportation. I refused to take any money, so I should say that much. But those scientists grilled us for 7 hours. Didn't even take a lunch break. And 60% of their questions were directed right at me. They would look down and they would read a sentence that I had written. And all I could think of is what somebody previously from the company had told me, we better get this right because this is $2 billion for the company. And I was thinking, geez, $2 billion, what am I going to do? But as it turned out, it's a necessary evil. The bisphosphonates are working so well. However, a study just came out last month that said that 700 people with bisphosphonates and breast cancer had the same exact mortality as 700 women with breast cancer and without bisphosphonates. So that's the first paper that said there is no effect from bisphosphonates, the cancer bisphosphonates. Up until now, we even have discovered that bisphosphonates have an anti-tumor component. But mostly the thinking is the bisphosphonate, the cancer, when it's metastasized in the bone, can't go anywhere unless it can take over the osteoblasts and osteoclasts. And they communicate with each other, and the cancer literally becomes the boss and tells them what to do and what signals to send back and forth to each other. And if you have sick osteoblasts and sick osteoclasts, which is essentially what bisphosphonates do, the signaling, the cancer can't take over. It's having lazy kids. You just can't get anything done. So there are cancers. I went to England to give a talk on the pathology of all this at a World Congress back in 2006, and a British physician, oncologist, very, three-piece suit, very staid, elegant old gentleman, started crying. He said, if you take these drugs away from me, I'm going to have patients dying like crazy, because he had women who were alive 7, 8, 9 years after they should have been dead, if you looked at the stats. And the only difference was the bisphosphonates.
When you have a bisphosphonate patient come in with an abscess tooth, a infected root canal tooth, and they aren't healed.
Right. Well, really the only choice you have if they have an infected tooth is pull it, clean out the socket as well as you can, and you guys are kind of used to doing that anyway. And then with the patient, cross your fingers, both of you. That's all you can do. Yeah, Bob Marks at the University of Miami has said that we should be using CTX, but that's kind of in the same category as the prostate antibody, those studies. And, you know, that's been in the news the last couple of weeks. They're saying we should, it's just an irresponsible thing to use those tests. However, there are 3 papers now, 3, including his original paper, that are saying, at least with the osteoporosis drugs like Fosamax, there seems to be some correlation. If you get above a certain level, then you shouldn't be doing any work. If you get below a certain level, 150 is what Marx said. But there may be something to it. This still is early days for that. Right now, I don't think very many people are doing the CTX. CTX is a little chunk of collagen that is in the bloodstream, and it gets in there from bone that is forming, new bone that's forming. And it's what the osteoporosis experts have been using for decades to follow patients. As a follow-up tool, it's fine, but as a diagnostic tool, 1 time or even 2 times doesn't seem to do much good.
So if you have a CTX number of 40, it's okay to work on, but they have a 495?
Right, yeah. That's the theory right now. Only a little bit of proof that works. And we just need bigger studies. One of the things that seems to be strange about this is much of it is on the lingual side of the mandible and the posterior mandible at that. And we started seeing an oral path back in the 80s, little ulcers that were exposed down to the bone. Of course, there isn't much tissue there, but they were linear. And we thought maybe it was from the muscle pulling on it, but they were all really above the level of the muscle attachment. And we're so really scientific in our business that we call them linear mandibular ulcers. And that's the only name. And they're only there's 1 paper about them. We all talked about it, but nobody wrote about it. And Fosamax came out in 1978. So it takes 3 to 5 years for the damage to show up as one of these ulcers, and I'm sure that's what we were dealing with. But this is exposed bone after surgery. A lot of the ones that I've run into have been spontaneous, but that's because of natural practice. My bias is patient referral biases. 10% of them are just spontaneous. Most of them are after an extraction, and 10% of them are on tori. Tori are naturally ischemic to start with, so if you put a problem into that area, then you're going to have some trouble. And this is a pretty classic one. Somebody came in with pain. They did root canal, another root canal by an endodontist then, and didn't work, so they extracted that tooth, and then they did the same thing. It's sort of like a trigeminal neuralgia history. They do 1 tooth and another tooth. And then the patient came in exquisite pain, and the oral surgeon could just take a forceps and move this whole alveolar bone back and forth. And that came out in 1 piece. Just to show you how effective this is, we reported this case too as just residual sockets. This is somebody, she was 3 months on Zometa, the cancer. She had breast cancer. She was doing fine on the Zometa as far as the tumor was related. She had a metastatic lesion, I think, in her femur. And so we knew that she was going to have a problem, and we pulled the teeth as gently. I don't know how you can gently pull a tooth, but as gently as we could. I didn't do it. The periodontist did it. Did it in 3 appointments, and then a year later, this is what it looks like. I mean, it looks like, I think this one is partially healed, and maybe this is partially healed. And otherwise, it looks like they were extracted yesterday. That's how slow some of these cancer-related bisphosphonates can slow down bone turnover. They say that the cancer-related ones are never out of the body. The only way you can get rid of Zometa in your skeleton is to get a new skeleton. And at my age, that's going to take me about 14 years. Some of you, maybe 7 years. So that's the only way to get rid of it, and it remains active throughout that time. It's a really weird drug in those 2 characteristics. Fosamax and the osteoporosis bisphosphonates probably maybe 3 years. Some people are saying within 6 months it's down to a half-life or half dose. So, but this is pretty dramatic proof of how much it can stop bone. And here is that linear lingual mandibular ulcer. This has started to heal centrally, but it was a single ulcer over this little torus. And I was the first one to report this, just spontaneous bisphosphonate osteonecrosis without bisphosphonates. I reported 7 cases, mostly from Houston. And I guess that case that I had from the 1970s I could include in that category. But here's somebody, we see that there was bone destruction. This is about 4 months apart. And the periodontist who did this case just kind of laid a flap and cleaned off the bone and put it back on, and the pain was gone at that point, but it came back. And then the bone was worse than anything. And this was osteomyelitis, not osteonecrosis, when the tissue was looked at. And this is just a chunk of the cortex. It just eventually worked its way up to the surface. John Helstein, a friend of mine, oral pathologist at the University of Iowa, was the first to report that at a meeting. I don't think it's really been reported in the literature. But he reported just tiny little bunches of cortex would come up to the surface, like a sliver coming out of your finger. And so I've been, just for want of another name, I've called these the itty-bitty pieces of Helstein. There is no name for them, they're just cortical chunks. Well, I don't know where it's coming from, but it's not in direct contact with it. And there never was. I followed this patient about 4 years, and there was never any problem. This came out, and it all healed. He had a little perio defect that is being managed by the periodontist. But I know what you're saying, but I have no proof of that. Yeah, this is the same patient. This is what it looked like with this X-ray. Yeah. I never figured out what it was. Never had a lot of, no real pus, no inflammation around that. You know, I don't want to this isn't a bisphosphonate lecture, but it's getting to be that way. And I just want to say that really how we're handling that now or recommending is just treat it like gingivitis. You treat the soft tissue when it gets inflamed. You can use antibiotics, topical or systemic, use chlorhexidine, whatever. Get a little curette under there to clean out. Just presume that it's marginal gingiva and treat it accordingly. Yeah. Yeah, his comment was using ozone for these, and there is one paper that was published about 8 months ago using ozone on these, but they were the Fosamax type of cases. They're smaller and they're easier to handle, and their conclusion was it worked very well. One place we're at is trying to figure out what bone is going to be susceptible to this breakdown on people with Fosamax or any other bisphosphonates. And somebody has used Tech 99 scans. The technetium goes to attach to the hydroxyapatite crystal, the bone crystal. And so any place you've got new bone formation or bone being destroyed at a high level, you'll see a black spot, a hot spot. And they had a pretty good correlation. If there was a hot spot there, that was the patient that broke down the overlying soft tissue. But we don't have any really good way of finding beforehand, predicting who's going to have this. Bone marrow, when I get pieces of this, well, the bisphosphonate, it's just dead bone, covered with pus and bacteria, usually filamentous, sometimes actinomycosis. It's acute osteomyelitis. That's all I can call it microscopically. So I have to put a note saying, as you know, this is consistent with bisphosphonate-associated osteonecrosis. And if they give me that clinical information, then I'll say this is consistent with your clinical impression. So we call it osteomyelitis, but we know it's osteonecrosis. because the pieces we're getting are just superficial pieces. At a meeting at Oral Path Academy last year, I think it was out of Harvard, they had some hospital cases where they actually took chunks of the whole mandible all the way down to the inferior border. And I think there were 8 of them that they looked at, and they tried to see what was going on with the marrow, and it was all fibrosing osteomyelitis. But I'm not sure if they would recognize ischemic marrow, and they didn't send them to me. Well, the only other thing, just like radiation carries, is the only equivalent to meth mouth. Radiation osteonecrosis is about the same thing. The same kind of pain. There probably is a lot more pain with this. And the difference is with this, the treatment is to get as far back as you can and try to get into normal bone that's not been irradiated. With bisphosphonates, the whole skeleton's been irradiated, so we're kind of stuck. You can't keep cutting back until you're down to the toes. It just wouldn't be very helpful. And I told you about the perforated palate with cocaine. There are a few other reasons for this. This is from an old dental journal, 1845. Remember, the first one was 1839. And we've also had, this is a completely painless case for this patient. This was midline lethal granuloma. Until 10 years ago, we didn't know what produced it. Now we know that it's a special form of lymphoma, angiocentric T-cell lymphoma. The leukocytes look okay, and they concentrate around this dead piece of blood vessel. And it's essentially shuts off the blood flow. And this is a Vietnamese man in Houston, and you can see this is what it looked like when he got to us. And he had already been under treatment by several physicians over a period of 3 years at that point. And nobody could make the diagnosis because they were biopsying the soft tissue. It was this always secondary infection that made it look bad. Same problem always with midline lethal granuloma. But you can see that's a huge amount of destruction, and this went on for 3-4 years with very little pain. And Chris, you mentioned Wagner's. This is a case of Wagner's from West Virginia. And this isn't pus. This is just dead chunks of bone that are exposed, and you can see not much inflammatory response. And we're looking right at the sinus. Wagner's can do that. So we've had experience with osteonecrosis before this bisphosphonate came along or the crack cocaine came along. But we called it, for want of a better term, we just called it cocaine osteonecrosis and left it at that. And we have, we're submitting 3 more cases to a journal sometime in the next 2 months. Well, then we started looking more carefully, and there's something we just call cocaine erosion. Erosion is a thin part of the epithelium, and usually it means the top is thinner. And we did a biopsy of one of these, and it is an indentation because the epithelium is not as thick in that place. And it has kind of a grayish look, a little bit yellowish in this view, but it just looks pale. And then you look more carefully and let the light hit it, and you see that there's a tiny little indentation. This is like a little crater. And that was exactly where the patient kept, I think this was cocaine, yes. Well, I put a few pictures, by the way. There are lots of websites that say if you touch this stuff, this is what you're going to look like in 9 months. So that's what all these pictures are about. Here's a little bit of keratosis. Somebody put it right there, and I think this will hit home if I tell you a story I had about a year ago. Just a gorgeous 60-year-old woman. I'm pushing 70, so that's okay. But absolutely beautiful. Obviously came from money. I saw her in the faculty practice, and she just looked like she put a lot of time into her upkeep. And she got in the chair, very bright lady, and I looked in the mouth, and I'd just written about all these things that we have been seeing in cocaine users. And I looked in the mouth, looked just like that, and otherwise she was pretty pristine in her hygiene. And I said, well, how many times do you put your cocaine in that place? And she just looked up at me and says, how did you know? And got out of the chair, and I never saw her again. So, maybe that's something that we should be looking for. Another way that we've seen cocaine effects is this blister. It's like an aspirin burn. You can kind of, if you use your tongue blade or your finger, you can scrape off maybe half of it or 3/4 of it. And it stings a little bit to touch. And, we don't see much in the way of aspirin burn anymore, but this is the closest that I've come to it in urgent care. This is what really threw me off. This is classic leukoplakia. It's well demarcated. At the border, it's got this rough surface, so it's more dangerous than a nice flat leukoplakia. And we saw many of these. We biopsied several. There was never any dysplasia. And then finally, C.D. Johnson asked one of these people, "Do you put anything there? Is that why you're getting this?" And he said, "Oh, yeah, that's where I put my cocaine." And since then, he started asking people, and I think we've got like 8 or 9 cases of this that we will be reporting eventually. Here's one that was bilateral because this guy kept switching sides. And I think it's a combination of drug burn and frictional keratosis from the powder, the abrasiveness of the powder. And the thing that really throws me off is it's so well demarcated. It's not like a smokeless tobacco lesion, like a snuff pouch, where it just kind of blends into the surrounding mucosa. This has that sharp margin like leukoplakia. There was a time, sanguinaria, that still could be part of this talk. Sanguinaria, Colgate toothpaste really increased the dose of sanguinaria, soap, in their toothpaste. And we started to see exactly the same kind of stuff back in the late 80s. And somebody even found dysplasia, and somebody found one carcinoma and reported that. And we started saying, we asked, people started to say, well, that's where I forget how we figured that out, or even who figured it out. But we finally figured out that it was sanguinaria that was involved. Every one of these people had used Crest or Colgate toothpaste, and the company had finally admitted that they have high doses of sanguinaria. And eventually they went down to very low doses of sanguinaria. And we don't see that anymore. So I thought this was maybe going to be sanguinaria, but none of those people, most of the people don't even use a toothbrush in the urgent care clinic. And for people who put their tobacco back here, it seems to spread around a little more, so we get a thin film of leukoplakia, and then we get the thick area with a little better margin. And if they have concentration of cocaine in one place, it'll actually burn, make an ulceration of the mucosa. And if it's heavily keratinized mucosa, as we see here, I called it excoriation. It looks like mice have been chewing on the keratinized tissue. So I've not seen that outside of lichen planus patients in heavily keratinized surfaces. But I've only seen this with cocaine users, not even crack users. And we have had at least this one patient who did have a lichenoid reaction. And so we said, well, switch it to the other side. And she switched to the other side, or he switched to the other side, I can't remember now, and got the same thing starting over on the other side. So I guess some people can be allergic to cocaine. And there are a lot of systemic problems, but this is the kind of thing that can be very productive. It has a lot of activity involved in getting to the point of using crack or cocaine. This is somebody who had that excoriation. You can't quite see it, but there are red areas, and then there are some actual hemorrhagic areas where he was scratching his forehead all the time because of coke bugs. And then crack is a little different because you use a pipe pretty much all the time. If it's not a paste in the mouth, you use a pipe, and you can get cracks from the pipe stems. Or if you're using a really cheap pipe, you might actually get an abrasive because those are clay pipes. Most of the pipes are pretty cheap now and very fancy looking. You put the crack in there and get it burning, and it will burn all by itself and give you something about 20 minutes worth of a smoke. And of course, that pipe stem gets very hot. So if somebody comes in with a burn on their lip, there's almost nothing else you can think of that would do that, except maybe marshmallows over a outdoor fire. And there we go. And so thermal burns, these are like any other thermal burn. It would heal in a few days. But we had a bunch of them, probably dozens by now, that have this kind of, I just call it crack pipe chylosis. I think it's just from chronic thermal damage or injury to the mucosa. And you can see that same kind of excoriation and keratosis on the thumbs or the fingers that hold the pipe because it gets very hot. And this makes sense, but this is the only case we've got of this. Somebody said that I just sucked in too hard and I got some of the small rocks that were burning and they fell on my tongue. And so these are, for want of a better name, these are in the healing phase, but they're thermal tongue burns, and I guess that makes sense that could happen. And then most of the time, somebody, when they're willing to admit that they use cocaine and they're coming in for a dental problem, they usually have a very dry mouth, and that lends itself to a hairy tongue and coated tongue. And this is just a quote. I won't keep that up very much, but they're not taking care of themselves at all. And it's kind of ironic, isn't it, that cocaine used to be used as a medicine, given up by dentists and physicians alike. Only 15 cents, instantaneous cure of toothache. And this is something that's kind of interesting. This was a woman, I think. She kept, this was cocaine. She would put it back here. You see a little bit of destructive soft tissue here. But this is a combination of erosion. It's just gouged out, cupped out the enamel, and abrasion. There's a combination of physical as well as chemical destruction going on here. And it makes sense because there's powder, and the powder gets on the occlusal surface, and she'll be grinding. And that part is well understood for any kind of powder, including chewing tobacco. And then when you put the low pH in there, you've got an erosion problem. And then another thing that we can see in the mouth, cocaine use is very upsetting to the stomach for people who swallow it. And that's generally what they'll do. If they put it in the mouth at all, they'll eventually, when the effect wears off a little bit, they'll chew on it and swallow it. And that upsets their stomach after a while, so they'll have gastric reflux and you get regular erosion of the posterior palatal surfaces of the teeth. So I think we should probably get into the next topic. Those are the main things. Methamphetamine and cocaine have the main effects in the mouth. Heroin doesn't have much to do in the mouth except to make it very, very dry. But, of course, heroin is a really vicious type of addiction. And I'm moving away from the camera here. Why don't I just switch to the next module here? Back in my early days, my master's thesis was the largest ever prevalence study of oral lesions. We looked at actually 32,000 adult mouths. You had to be 35 years or older to come to the screening clinics, and these are in 17 cities around Minnesota. And most of that was already done, but before I became a resident, it was my job to put it all together, to analyze it. And I ran the last, I think, 5 of those clinics. The value of those prevalence studies, and actually the 53 most common lesions that you have on the Bouquot to go, has those, that's the prevalence study. The lesions are put in order, number 1, number 2, number 3. And as far as I know, that's still the standard for prevalence of any oral lesions. The value of all of that is we had oral surgeons and oral pathologists looking at everything. There were community dentists doing the screening. Anything that was abnormal, they would call one of us. And that's the only oral cancer screen or oral screening that has had oral pathologists or diagnostic experts in it. So I got into this early on. And I was involved in this thing called leukoplakia. And when I went to name my thesis to show how much controversy there was, I mean, NICO is almost nothing compared to those early days. My advisor would not allow me to use the word leukoplakia. And I asked him, what name would you like me to use? And he said, I don't know. So I made it up. My thesis is nonspecific clinical keratosis in 24,000 mouths. I guess we had to throw out some of the early exams that we did. So that shows what the controversy was, and now we're back in that place because we have new technology. But there was a guy who wrote a paper back about 20 years ago, and he said, why do people like Bouquot always talk about the white lesions? The red lesions are more important. And he's right, they're more dangerous. And so I contacted him. He was in New Jersey. And I said, why don't you and I write a paper about this erythroplakia? You like the red stuff? I like the red stuff. I just don't write about it. So I'll write it, and you put in your opinions. And, you know, I wrote it, gave it to him. He didn't change anything. His opinions were exactly the same as mine. He just had this idea that I should be writing more about red stuff. Well, as part of that paper, I called it the dangerous mucosa. And that name is stuck for erythroplakia. That is kind of the secondary name for it. And we're really getting into a place that makes me wish that I was younger, because new technology, every 6 months something else is coming along that is going to make this even better. All along, whether we're using new technology or using the old eyeballs, you're not going to find anything unless you're really suspicious for it. I've had people tell me, I've never seen an oral cancer. And then the guy down the street says, you know, I've had 5 oral cancers come over to me from his office. And it's just, I was just helping to defend a poor guy. He's been a dentist, family dentist in West Virginia for 50 years. And the patient came in, he pulled an upper tender, pussy third molar out and totally missed a 2-centimeter ulcer of his tongue that was 2 months later diagnosed as squamous cell carcinoma. You just can't do that. You can't focus on one thing. You're dealing with the whole mouth, and actually nowadays it's the whole maxillofacial structure. And cone beam CT scans are really making that clear, that we're going to be responsible for a lot more than just the mouth. But you have to be suspicious every time. It's sort of like infection control. We assume that every patient has AIDS, right? We treat them all with infection control as if they've got this bad infection. And we don't want to get it, we don't want to pass it on. That's how we handled the AIDS situation. And I think this is kind of the same thing. You just don't let up your guard, ever. Every single patient you look at least that first visit in a year, you do an oral cancer exam or a soft tissue exam or whatever you want to call it. And you know the numbers, I think probably as well as I, but these numbers vary depending on whether people include the lip, the skin of the lip, the vermilion, the inside, soft palate, tonsil area. So these numbers can be as high as 30 out of 100,000. But this really, I think, these are the numbers for the actual mouth, from the vermilion back to the soft palate, not including the tonsils. This is what you can bring to your local community if you're giving talks on this. And I might add that there is a little oral cancer and precancer talk in the 53 most common lesions. So you could just take that right out and use it to talk to physicians or whatever group you want. This is, in males, the 6th most common cancer. If you put all the head and neck things together, it's about the 4th, sometimes 5th most common cancer in America. And that includes only the males. Well, I was on the National Board of Directors of the American Cancer Society when they decided, you know, we don't have money coming in the way we'd like it to come in. If we want more bang for our buck, let's just take the most common cancers and really publicize those, put our research dollars into those. And so they did that. But during that debate, the question is, should we take the top 5 or the top 6 or the top 7. And they chose 5. But if they just voted a little more, we'd have all kinds of oral cancer information from the American Cancer Society. We just lost out by 1 vote, and NIH did the same thing. They decided to focus their research dollars on those top 5 cancers. And it does produce a certain number of deaths, but 6,000 deaths among 300 million people is not, I hate to say it, a public health issue. So it's not sexy in that regard, and doesn't get a lot of impact relative to education or public information. It's mostly an older person's problem. We are seeing oral cancers now in young people. I had a lawyer from Illinois send me a case. I don't do a lot of legal things, but this was interesting in that it was an 18-year-old girl with cancer of the lateral border of the tongue. And, of course, the dentist kept dinging around with it, cut it out, never sent it off for biopsy, because who would think of tongue cancer in an 18-year-old girl? And so eventually she died. But that was a pretty phenomenal case. But it is almost classically, quintessentially, an older person's problem. We almost never see it before 45 years of age, but we are seeing it now. So we can't quite be as strict about the old age thing. Tongue cancer in particular, I just talked about this issue. It's being seen in younger people. And if, in fact, we can find cancers at a very small size, like I like to think of 1.5 centimeters as the key. We want to find all the cancers in dentistry at 1.5 centimeters before they get any bigger than that. But 2 centimeters is what some authors prefer. And this is why. If we look at the black population, 59% of them are large. This would be stage 4 automatically. And only 44% of the whites are large. And conversely, the smaller ones, there are more of them in whites than in blacks. So it really isn't a racial issue. It's more of a poverty or socioeconomic issue. But there are those things that come into play. And then we have a lot of things that look alike. I mean, squamous carcinomas can look like a lot of things. It can be an ulcer. It can be a papillary mass, a verruciform mass, a fungating mass like this thing. Or it can look just like a pyogenic granuloma. Classic. I've been fooled by squamous carcinoma of the gingiva because there's so much secondary infection that they look exactly like a pyogenic granuloma. And then there are those that are just white. They've just started to invade and they look like leukoplakias. And then there are those that are red, those erythroplakias that I talked about. And here's one of the key problems is no pain. I told you, the dental director for the state of West Virginia. I had access to the raw data, so I went into the data set and determined the size of cancers that were submitted. I determined the source of the cancer. Was it diagnosed by dentistry or medicine? And I had been the pathologist for the ENT department for 15 years. I was the guy showing the slides at the weekly conference, and I kept all that data. And then I had the biopsy service, which got all of West Virginia dental biopsies. And I knew from my biopsy service that the average cancer coming into my service from dentists was 1.7 centimeters. I knew from the head and neck pathology people, the ENT people, that the average cancer that they saw the first time was 4.2 centimeters. So I knew dentistry was doing something right in West Virginia and probably in every state. Then I got to be the dental director, and I found out that dentists are only finding 10% of the cancers. If people have a mass in the mouth, they go to see their physician. They don't go to see their dentist unless it's on the gums. So that's a real problem, and it shows what dentistry can do and how frustrating it is for us to do it. These are just different variations, and they're in the 53 most common lesions. Oh, by the way, this one in particular, I swore that was a pyogenic granuloma. And it was only until we looked at the biopsy that I was proven otherwise. This was a cancer that was thought to be an erupting third molar in like a 50-year-old, 52-year-old person. Went to the emergency room. A physician took a tongue blade and tapped on it. It sounded like a tooth. It echoed. That's how hard the cancer was. And so he just gave the patient some antibiotics and said, be on your way. And it was several months before the patient came back, and most of the ramus was destroyed. So what we want to do is try to get some small stage 1 lesions, because if we can find them at that very early stage, they're, depending on the location, there's almost a complete success rate. And we haven't had a great increase in success over the years because of different surgery or public education. We've gotten oral cancer survivability, and that often is a deformability also. You're in a pretty deformed state, from 43 up to 57, and the latest figure from a paper about 6 months ago was 58%. So this is what the best surgeons in the country can do. They might give maybe a 10% boost to survivability. But if you as a dentist find that case as a very small cancer, you can increase the survival, you can double the survivability. Yes. Velscope, let's get into that. I like that, but there's a lot of controversy in my business about that. Well, what we want to do, this is what we knew about cancers, and I'll get into a little bit about what we knew about leukoplakia until all these gadgets hit the scene about 12, 13 years ago. We knew that the further back a cancer was, the worse was the prognosis, but that's because they don't see it further back and it gets to be bigger. We also, and it's closer to the lymphatics as well. And of course, we know that it's worse with the larger size. That's what the staging procedure is all about. If you have a posterior tongue cancer that's 4 centimeters or more, you only have a 1 in 4 chance of being alive in 5 years. We know that if there is a metastasis at the time of diagnosis, the prognosis is worse. It's down to 36% with the MET. Without a MET, it's 65%. Unfortunately, 40% of people with oral cancer have a metastasis at the time. This is a palpable metastasis at the time of diagnosis. And then, of course, the longer it is, the larger it's going to be, the more chance of metastasis. This is kind of odd, and it's a bit controversial. The cancers that are found in people who don't smoke, don't use heavy alcohol, don't have heavy alcohol use, don't have any factors that we can identify that might cause this. Those are the cancers that seem to behave very badly. They move very rapidly, and the prognosis is less. We also know that prognosis is less in younger individuals. I don't remember that 18-year-old girl, but I got a call from one of my old students. His son was in the freshman year at the University of Florida, and they diagnosed a cancer of the tongue, squamous carcinoma, and he asked me he wanted the slide sent up to me to look at. I was in West Virginia at the time, and I did that, and within 5 months, his son was dead. And it just moves so fast. It's frightening how fast the cancers move in young people. And this is a point that I made in a paper out of my Mayo Clinic studies. The cancers that didn't have any adjacent leukoplakia the prognosis was much worse than if they had a leukoplakia. So it's almost like saying, gee, you ought to smoke more to get those precancers so that you have a better chance of surviving the cancer. And the bottom line is we can make a difference. We just have to keep trying, every single patient. And, of course, these are all surface cancers, so from a legal perspective, if you miss it, it's the same as a dermatologist missing it. The courts assume that you can see all surfaces in the mouth, and that is probably a safe assumption. And I've had a lot of experience. I've helped maybe 100, 140 types of legal cases, not going to court, just informally talking to lawyers and giving them my opinion. And that is, I do know, because most of those were students or colleagues or friends of mine, the dentist that was involved. I know that it just hits really hard. If any of you have had that thing happen where you miss a cancer, it's just devastating. You think you don't want to do dentistry anymore because you're so bad at it. And it's really not true. You just missed the case. And if you look at that 53 most common lesions, cancer was number 25. And the lawyers know that, so that's been used in court, that this is the 25th most common cancer and you didn't recognize it. And, of course, this is the one where most of the lawsuits, successful suits are made against somebody missing a malignancy. So, Oral path doesn't make you a lot of money. It just protects you, keeps you out of the hands of the court, and protects in that way. Here's somebody who put over $30,000. This was an Indiana dentist. He put in over $30,000 of pros, essentially, and kept just curetting this area that was messing up his crowns. And after 18 months, the patient went to an oral surgeon who biopsied it, and this is all squamous cell carcinoma. And here's an orthodontist. This is the fourth Hawley retainer. And the bump in the hard palate was getting bigger and bigger. The patient kept coming in every few months saying it doesn't fit anymore. And the assistant, the orthodontist assistant, was remaking these. Never even saw the orthodontist. So he lost his license, and he lost his license because of that. The orthodontist lost his license temporarily. And this is where we're at right now, and where we've been at for quite a few decades now. We're trying to see what's on the surface and predict what's beneath the surface. And some of these devices have helped dramatically in that regard. And it is important because if you look at prevalence of leukoplakia, it's not so uncommon. This was my study for my master's thesis. I published it many, many years after I wrote the thesis, actually. But we had somewhere around 3%, a little under 3% of all of those adults that we saw had a leukoplakia. And it didn't make sense. If you think about your practice, do 3% of your patients have a white patch in the mouth? But then Tony Axel published his PhD thesis out of Sweden, and there they can tell you, you must show up at the clinic at 8 o'clock on Thursday. So everybody, he saw everybody in this community. He had 20,000 adults he looked at. I had 24,000. And the numbers, and of course, we're Minnesota, so Northern European stock, and our numbers were almost identical. I had 2.8, he had 3.3. So we know that the numbers are reasonably correct, at least for that population group. And there is no place in the body that has the variety of oral precancers that we have. So if anybody should be trying to come up with a better tool, better technique, it should be us. But we've always been following the physicians in this regard. We've mostly been following the GYN docs because the cervix is sort of the role model for oral leukoplakia and other precancers. And for our textbook, I just took them and I gave stars. I didn't want to give exact numbers, but you can see that some of these have a higher risk, sort of a 6-star risk compared to others that are only 1 or 2 stars. And every dentist has to know about those things. And that list is in your 53 most common lesions. There are some numbers available. I don't think they mean anything. We're going through a follow-up period right now. Most of these are from the 60s and 70s when follow-up studies were really a hot deal in oral precancers. But they're being done with better techniques, better technology, and so I think those numbers will change. But we do have numbers, general numbers at least. And for leukoplakia of all types, I usually tell patients about 4% chance of going on to cancer, lifetime risk. But if it's under the tongue, even though it looks the same as what's on the buccal mucosa, you should say about 20%, because under the tongue is such a higher rate that in England, for the last 40 years, they've called it sublingual keratosis. It had a different name. We don't have a different name for the leukoplakias. We have different types of subtypes of leukoplakia, but we do have this thing. I don't know how familiar you are with PVL, proliferative verrucous leukoplakia. By definition, it is leukoplakia that is more than 3 centimeters in diameter, or there are more than 2 leukoplakic lesions, so 3 or more leukoplakic lesions. That's the definition. And if you have that, then that's your clinical diagnosis. I'll just give you hyperkeratosis with or without dysplasia on a biopsy. I'll never put this on as a diagnosis. But if you give this diagnosis, then you are saying, you, my patient, have a 50 to 80% chance of getting a mouth cancer. And it's not unusual for multiple oral cancers to develop in that disease. So we know this is the high spectrum of the leukoplakias. And we discussed all that. The World Health Organization about every 15 years gets together and they talk about oral cancers and precancers and what things are really precancers and what are the risks. And it's like a 4-day meeting. It was wonderful. I represented North America. There you can see. And only about half of us were the actual panelists. Others were invited to sort of sit around the outside of the room. And we decided new names, and we decided these are going to be the leukoplakias. And believe it or not, lichen planus, which I truly believe is a precancer, was voted by this group to not be a precancer. The thinking is cancer is common enough, leukoplakia or lichen planus is common enough, so sometime they're going to meet together. And I've just had probably 8 or 9 of my lichen planus patients I know have developed cancer right in the area of the lichen planus. So I find it hard to believe the literature, but that's what the literature says. So we voted on that, and nobody listened to that part of the discussion. Everything else is pretty well accepted. When I got that picture, by the way, I remembered my parents' 40th wedding anniversary in Florida, and I looked a little different back then. This little guy is finishing up a PhD in economics right now. Well, because this has been so difficult and unpredictable, or not successfully predictable, there have been a lot of new devices that have come out on the market, some of them claiming much more success than they're worthy of, I think. But these are the devices, and I'll just go through each of those fairly quickly. These have been around for a long time. We know that the name leukoplakia is a clinical term meaning a white patch. Can't scrape it off. And get this, you can't give it another diagnosis. So you have to know every single white patch that can occur in the mouth and look at this one and say, nope, doesn't fit any of those. And then you can call it leukoplakia. Now, what kind of a cornball definition is that? We argued about that. As a matter of fact, the head of that World Health Organization panel task force is from Australia, and he admitted he came here swearing to get rid of that word leukoplakia. And at the end of 4 days, we all said, ain't got a better name, ain't got a better definition. That's just the way it is. So that means you're responsible for being a little sharper with this lesion than with other lesions. And we're getting some help in that regard. But these other things have been around for a long, long time. The clinical appearance. Pinborg from Denmark is the one who started us saying, hey, wait, I can look at a leukoplakia and I can tell you this one's good or this one's bad. And he was right. When he came to the United States to our American Academy meeting, the crowd laughed at him. They literally I couldn't believe that we could be that rude to the guy who was the acknowledged premier orthopathologist of Europe. And now, if you look in our book, his rules are what we have in our textbook. All the textbooks are like that. That's what we teach. We teach his way. So he won, but it was pretty painful for him. Toluidine blue has been legal to use to try to find precancers in the mouth in Europe, and I think in Canada for many decades now. It was only recently approved in the U.S. about 3 years ago. So let's just quickly go through some of this. First, there was a human eye, and that's where Pinborg came in. He looked with a very critical eye, and he followed different appearing lesions. That was the key. Pinborg was the classic follower of lesions, and so he's the one who his follow-up studies determined that lichen planus. He found 1 out of every 200 lichen planus patients went on to cancer. And that's still the best information we have today, even though we discounted it for that WHO project. Leukoplakia has been around for a long, long time. Originally, the name meant that white patch on the tongue of syphilitic glossitis. People have syphilis, they get this white stuff, and they have a 1 in 4 chance of going on to malignancy, a tongue cancer, if they have that kind of a tongue. And we have gone on to look at different things. If it's a large patch, but it's smooth on the surface, we're less worried about that than a smaller patch that has a rough surface. I mean, there are those kinds of general rules that we've come across. But the term itself has been around since the 1870s. And, of course, this is straight out of the precancer section of the 53 most common lesions. And these are the lesions that have been they've been called leukoplakia over the years. Little frictional keratosis, that name was peeled off 20 years ago. I think I did it. I don't know anybody who used frictional keratosis before I put that in our book chapter. And now it seems to be pretty common. But remember the diagnosis. If you can call it something else, then it's a different person, a different thing, and it has a different biological behavior. So frictional keratosis is not a precancer. Chronic cheek bite, that was peeled off 50, 60 years ago from leukoplakia. Smokeless tobacco keratosis is another name that I made up, and I was in West Virginia. Of course, I saw a lot of it. And that means that now I give it a different name. That was in 1980 I did that. I give it a different name, and with a different name, it doesn't follow the leukoplakia biological behavior. And it is maybe 1/10 or 1/20th less risky for cancer than real leukoplakia. And then about 4 years ago in the ADA Journal, a friend of mine from South Carolina wrote about this thing. It's a rough surface keratin. It looks like rough leukoplakia, granular leukoplakia, but it's right here in the retromolar pad, and it's often bilateral. And it's fooled us for a long time. A lot of rather more than minor surgery has been done to that area because we've been telling people if it's got a rough surface, that's a bad sign. Well, after looking at 1,000 biopsies of this, there was only one that had even mild dysplasia, so they called it alveolar keratosis. So that's the latest white lesion to no longer be called leukoplakia. Lichen planus peeled off in the 1960s. Lichenoid reaction peeled off in the 1990s. Geographic tongue was once called leukoplakia. That went the way of the wind it became a new entity or distinct entity in the 30s. Leukodema became a distinct entity in the 50s. Nicotine palatinus in the 70s. And nicotine palatinus was an odd one because it is tobacco related. But it's the thermal effects of tobacco, not the carcinogenic effects that produce this lesion. So we've got that funny name. And I've already told you about the cocaine stuff and marijuana. And I've also told you about the site specificity. And you remember from that increasing risk drawing that when we have spaces in here that are too immature to even make keratin, that's a really bad sign. And that's the place you want to biopsy. Get a little bit of the white and go into that little plateau. And erythroleukoplakia is just red. You can't let erythroleukoplakia go more than maybe a month because it has about a 90% chance of having dysplasia or some kind of malignancy already at the time of diagnosis. And I've already talked about PVL, and we've already gone through this. We've got a lot of gadgets, and only, can I have 10 minutes? 10 minutes to get through, but I should be able to do that. The gadgets are helpful, but you're the person who's using it. It's not using you. There is no device that you can shine in the mouth or coat something on the membrane in the mouth, and it will give you, yes, this is definitely a precancer. This has bad cells. This has dysplasia. You always have to compare your clinical impression and just use your head. You're the doctor. The device is not the doctor. So all of these require a certain amount of intelligence and just practical wherewithal. The microscope was probably the first of the devices that we used to study this, and that's when we found that leukoplakias have dysplasia, some of them. And those dysplastic cells look just like squamous cell carcinomas, so that's how we decided, well, this must be a precancer. And we now know that that is still the standard. If we want to predict what's going on to cancer, what is the risk of this leukoplakia going on to cancer, then it's the level of dysplasia. Is it mild, moderate, or severe? That gives us the best prognosis. We have lots of molecular markers that are being studied. Lots of them look really hopeful and helpful, but they're all still in the research phase. And right now, they're not helping us very much. So it's still the standard stuff that I would give you in a biopsy report. And just to show you how critical this can be to the patient, this was my study out of the Mayo Clinic. It's the only population study ever following